Thank you. Good afternoon from Buffalo, New York. I'd like to thank Dr. Walker for the opportunity to present at the NCBH Digital Education Series, which is a really novel concept, especially during this pandemic. But I'm hoping we can continue to do things like this later on because that has brought a lot of value, certainly to me during this COVID time. So I'm a vascular surgeon. I practice in Buffalo, New York. And one of my interests is aortic aneurysms. As a woman surgeon, I have a lot of female patients. I get a lot of female consults. And I do like to think that we need to be treated a little bit differently. And you guys can chuckle at that. But even when it comes to your aneurysm, I think women aneurysms need to be evaluated and treated a little bit different than in men. And I will point out to you why. So when I was a resident, we were taught AAA is a man's disease. And the reason I put this up there is really to explain to you that mostly men over the age of 65, they're smokers, they have a family history, really get screened. But women are at risk as well, especially if you have a family history. And this is an interesting journal that looked at aneurysms in women. And we were taught, at least when I was a resident, we were taught 10% of aneurysms happen in women. That's no longer the truth. This is a nice article that was published in JVS in 2007, where the incidence actually is 20% women have aneurysms. Women tend to be older than men, so they have more comorbidities going in addition to advanced age. And really, women should be considered more for AAA screening. Here's another little interesting caveat. Women tend to rupture aneurysms at a smaller size. So this is a study that was done both in a European combination, at the Finnish study, the Canadian and the US were looked at. And we found that women ruptured at less than 5.5% at a higher rate than men do. Here's another interesting thing. They tend to grow faster beyond a certain point. So men and women aneurysms will tend to be about the same size in terms of rate of growth up until they get to about 4 centimeters. And then once you get to 4 centimeters, this is in a Norwegian study, they actually plotted that it goes up exponentially so much higher. So my take home message from that is when you're following a woman with a AAA, especially a smaller woman, you need to consider if the aneurysm's growing a little quicker, especially past 4 centimeters, they need to be evaluated more frequently than just like we would do for men. So how do we really learn about the natural history about women, especially in AAAs? And we tend to do that on EVAR clinical trials. And unfortunately, women are not represented well in the EVAR trials, and that's because they get excluded. So as you can see here, anywhere between 6 and the Aortic IDE was 29%, but really everywhere else, the excluder IDE, the Ovation IDE, PowerLink, they're between 10 and 12 and 13%. So we really don't have a good clinical perspective on women, how they do with aneurysm treatment in EVAR clinical trials so far. So the reason they're usually bounced out and they're not part of the inclusion criteria is because women are complicated, and I know you're gonna laugh about that. I think most of us women will say the same thing to you. Yes, we are complicated, but when it comes to our aneurysms, we have smaller iliac vessels and we have much more complicated necks. So they're called complicated necks or hostile necks because the length, the diameter, the angulation tends to be higher as well. So as a result of these things, there's much higher chances of injury in aortic aneurysms that we have seen so far. So the arterial injury rate is higher, the iliac access angioplasty stenting rate is higher, and a conduit rate is higher as well. We have studied mortality in women after endovascular aneurysms, both in Europe as well as in the US. And this study looked at the number of deaths, percentage of hospital deaths after EVAR. And as you can see, the red is the women, the black is the men. Across the board, it is higher, and it has not changed between 2001 and 2010. So we're not looking at really old, 30-year or 40-year data. We're talking about relevant contemporary data, which still shows higher hospital deaths. NISQIP did an interesting study, that's the National Surgical Quality Improvement, and they looked at independent predictors, and they came up with female gender being an independent predictor for higher length of stay in aneurysm surgery, in particular because patients who are females tend to do worse, either, as you can see, because their length of stay was higher, the readmission rate was higher, morbidity and mortality was higher. And this is a study taken from the UK analysis. So it's not just the US, it's not just the UK, it's European studies as well have all shown that women tend to have greater mortality and morbidity in patients. And in small series, large series, we're starting to see that. So the question really becomes, why is that? And I think most people will argue that there really wasn't an aneurysm graft created for women that would allow you to treat the iliac arteries because they're smaller in general, or the complex neck, as well as you would like them to be treated with a standard aortic graft. Which brings us to, can the Ovation platform then solve this problem? So certainly those of you who have used Ovation will agree that they have very flexible, trackable, low-profile limbs and low-profile device, which allows you to track, especially in a percutaneous case, in a person who has small iliac arteries, which can happen mostly in women, but also some men. And because the neck tends to be complex, hostile, angulated, short, can a polymer custom sealing ring help this patient? And that's what Ovation IX graft is really known for. If you look at the profile, which is a huge reason to want to treat women with a lower profile device, across the board, the Ovation IX graft is 14 and 15 French. It is the smallest that is available. In terms of data, being able to prove this, the post-market registry, the Ovation European data, when you studied them and you did a subgender analysis, about 14% of them were female. And if you looked at the 14% who were female, sure enough, you saw that these patients had more larger neck diameters, angulations, and lengths, as well as smaller access vessels. So exactly what we just talked about, that they had more complicated aneurysms than men. And when you looked at the results for 5 years, women tended to do as well as men did. And this was the first study that actually showed that the freedom from rupture, the AAA mortality, that patients did as well as. We participated in this trial, the Lucy trial, which was a first prospective study to really systematically evaluate how the Ovation graft does in men versus women. This was done over about a year. It was a 2:1 ratio. We looked at safety and efficacy, so at 30 days and then at 6 months and then at a year, and we basically saw how patients did. And what we found was 225 were enrolled, 140 something were men, the rest were women. And if you looked at them, the demographics again were very similar. Men and women tend to have the same players, ASA class 3s, coronary artery disease, hypertension, smoking history was the same, COPD was the same. So both patients were not, non-significantly were about the same kind of demographic. And when you looked at the complex anatomy, like we talked about, sure enough, the neck and the iliac access was a more complex phenomenon in women compared to men. And if you looked at access size in terms of IFU, you would see that the 14 French sheath allowed for both male and female, 96% of females, 99% overall to be treated on IFU, which would have fallen off for an endurant or excluder or a zenith graft if you went by IFU. So long story short, yes, in the Lucy trial, we saw that complex shorter necks, we saw smaller iliac vessels, and yet these patients had close to 100% deployment success. There was no difference between the men and the women. It was very amenable to percutaneous. Some people, who did general anesthesia did as well with local anesthesia. Procedural time was about the same. Device time was about the same. So for the first time, Lucy showed us as a prospective study, that females did as well as males with safety and efficacy as well as length of stay, similar ICU admission and 3-day admission, as well as adverse events were very, very comparable. There was one MI in the women arm compared to the men arm. It was not statistically significant. So patients did quite well. In terms of effectiveness for occlusion or stenosis or type 1 endoleaks or type 2 or type 3 endoleaks for that matter, there was no significant difference between men or women. So secondary intervention rate also, as you can see, was pretty low. So what that leads us to is women traditionally have had limited eligibility and worse outcomes after EVAR, and that's probably because the profile and the neck complex the complexity of the necks in women were never really identified and customized to. I think the Ovation platform allows us to have more eligibility for women to have EVAR treatment. And the data that is available now is 5-year data, which clearly shows women do as well as men, especially with an Ovation platform that uses both the smaller access as well as the polymer seal. And the Lucy studies certainly proved that as well, which was a dedicated study to look at this. So I'll leave you with, women and certain men can have complex aneurysms. They can have iliac vessel tortuosity, smaller lumen that needs to be looked at, and their necks can also be more complex. So spend a little bit more time looking at that and then deciding on which graft to use. In our experience of almost close to 300 patients now, of men and of women, we have found the Ovation graft to do as well as the men have done with our graft. So thank you again, Dr. Walker, for inviting me to present at this. I look forward to seeing you sometime soon, and all of you as well, and I hope this was helpful. Thank you.